The medication we're talking about here is buprenorphine. What it is a lot of times you heard about the trade name Suboxone. It comes in other forms as well, though. There's an injectable form of it. This medication was actually came about in 1985, and it's been used to treat opioid use disorder in doctors' offices since the year 2000. That's 25 years ago. A lot has changed in 25 years. A lot of science has happened. We've learned a lot more about how this medication works. What buprenorphine is, it's an opioid, but it's a partial opioid. It is not an opioid like morphine or methadone or heroin or anything of that nature. It has a ceiling effect. And that's important for safety perspective because this medication, once it gets in your body and once it attaches to the receptors and works like a medicine does, when it hits that ceiling, the effects don't get greater. And that's important because the number one reason people die from opioid overdose is they quit breathing. Now, I'm not here to say to anybody watching or listening to this that this medication cannot be abused or that it is entirely safe. But when we compare it to our other option, methadone, it's so much more safe than methadone. So safe, in fact, that our government, our federal government, allowed all of the physicians to prescribe it out of their office in the year 2000. Let's move forward a little bit. At first, I could do 30 patients total. About a year later, they said we could do 100, then 275. They did away with some of the required training for it because it's so easy to prescribe. They said you no longer have to do counseling along with it. We recommend it, but that's not going to be a requirement. In other words, over the years, the past 25 years, we've learned so much about the effectiveness of this medication that in 2022, all of the federal regulations were done away with. There are no longer any specific federal regulations regarding buprenorphine to treat opioid use disorder. So you can treat it. Any doctor, nurse practitioner, anybody with a DEA license can treat opioid use disorder from their office to as many patients as they want at whatever dose they feel is necessary. In other words, they can individualize the care to the patient they have in front of them because everyone's journey in addiction is different, and we have to have individualized care. So how effective is this medication, though? Well, let me tell you a little story myself. We've read about this. It's very effective. We have studies done and research in Kentucky that show its effectiveness in decreasing crime, decreasing diversion, and saving lives as well. Nora Valkow, who has been here before testifying in years past, she is the director of the National Institute of Drug Abuse, NIDA. She's been to Kentucky. She came here in October of last year. I sat on the front row right next to our president from the University of Louisville. I'm a professor there. Dr. Valkow has told us that if everyone who needs this medication, buprenorphine, could have access to it, we could drop our overdose death rate by 50%. And she said that's a conservative estimate. Now, last year, we had about an 8 or 9% drop in overdoses in this state. And that's great. And we want to tout and celebrate every drop in overdoses that we have. But we have more Narcan out there. There's probably a little less fentanyl in the supply now. And I think we are doing a lot of things to treat this condition. In other words, we've heard about these groups that have come up here, and they're doing things like, we have a lot of beds in Kentucky. We have a lot of access. People are working to get treatment to people. But what we're not doing is treating the actual disease of addiction that's causing the overdoses. And buprenorphine works in that part of the brain. It's like putting water on a fire. It works in that part of the brain to stabilize the part of the brain that causes the behavior. Right now, we have barriers to access to this care, unfortunately. A lot of it is stigma. People don't understand it. Part of the reason I'm here is just to educate you on this, because it starts with learning what this is. Because once we understand what it is, it's not trading one dependency for another. It's actually treating the disease of addiction. And the problem is that we don't have enough people that can prescribe it now. I mean, as I said, the federal regulations are gone, and most states don't have buprenorphine specific regulations. Only 19 states do. Kentucky's one of those states. And these regulations can't keep up with the science, no matter how hard you try, no matter how much you put effort into it. By the time a regulation passes, it's probably obsolete. The science is moving so fast, and the SAMHSA, you've heard about SAMHSA, the Substance Abuse and Healthcare Services Administration, the Federation of State Medical Boards, the DEA, HHS, I could go down the line. They all support low barrier access to this. And there's one group that I want to end on to let you know who supports this. And this may shock you. Because of those of you who are worried about diversion of this medication or what's going to happen with this, think about this. In January of this year, the HHS and the DEA published in the Federal Register that they want to allow buprenorphine to be prescribed by telephone without ever having to see a patient face to face. I'm not recommending that happen to everybody, but there's going to be certain cases where you might want to do that. The DEA, not known for being a group that will go easy on drug diversion. We look to them to do that, but the DEA, look it up. Look it up. In January in the Federal Register, Google it. This year, the DEA has said that you can do this. This is such an effective medication. We want our providers to be able to prescribe it however necessary, as long as they feel it's proper, as long as they're practicing medicine, and as long as they do, in this case, a CASPER report, for example, in Kentucky. So it's not the wild, wild west if we allow this to happen. Buprenorphine is still going to be a Schedule III drug. There's still a regulation in Kentucky that will govern all scheduled drugs. It's called 201 KAR 9260. There's a section in there where buprenorphine fits right in. But we have to enable and empower our prescribers. We have potentially 26,000 or so prescribers in this state that can prescribe this medication. About 2,000 or 3,000 prescribe it right now. Only about 20% of people who need this medication get this. Our overdose rate is at record levels still. We had about 245 or 6 overdoses in 2000. In the year 2000, we had almost 2,000 overdoses last year. We have a medication that can drop this overdose death rate, science says this, by perhaps 50% or more. We just need to empower our prescribers to do it. And House Bill 788, what it does is helps remove one of those barriers, and that is that the fear that prescribers have that they might lose their license or get penalized by inadvertently or just not following one of the regulations, exactly. And that does happen. A lot of prescribers that I talk to, that I know, they say, well, the best way I can avoid getting in trouble with the medical board or losing my license is just to not treat it. And that's really, really sad. Kentucky deserves care. We are doing so much in this state to fight this problem. There's one missing piece. There's a missing piece that we have, and that's to get our primary care physicians comfortable prescribing this medication that we know by science is effective. And I say this not just as a prescriber in Kentucky. I say this as a parent, as somebody who lives here. I'm a professor at the University of Louisville. I am the regional director of the American Society of Addiction Medicine. We are behind this, and I appreciate this House Bill 788. We've looked at this, and we agree with this. We feel it is a good bill, and we hope that you will consider that carefully. And I thank you for your time. If you have any questions, I'll be happy to answer them.